Good evening, and welcome to the January webinar presented by the National Keratoconus Foundation, which is a program of the University of California, Irvine. My name is Jason Marsack, and I will serve as your moderator this evening. Also with us tonight, Taylor Young from the National Keratoconus Foundation will be curating questions from the audience. So during tonight's program, if you have a question based on what you hear, you can type it in the question or chat box on the right part of your screen. We'll have some time during and at the end of the presentation to answer a few audience questions. It's my pleasure to introduce today's presenter, Dr. Muriel Schornack. Dr. Schornack received her OD from the Illinois College of Optometry in 1998 and completed a residency in primary eye care at the Illinois Eye Institute in 1999. Upon completion of her residency, she joined the staff of the Mayo Clinic in Rochester, Minnesota, where she is currently a consultant in the Department of Ophthalmology and an associate professor in the Mayo Clinic College of Medicine. She is a founding member of the Scleral Lens College of Medicine, a member of the Scleral Lens Education Society and the SCOPE, Scleral Lens in Current Ophthalmic Practice Evaluation research teams, and remains active in scleral lens related research activities. Today, Dr. Schornack will be talking about the results from the SCOPE study. Welcome, Dr. Schornack.
Thank you so much, Jason and Taylor, and thanks to the National Keratoconus Foundation for inviting me to participate in this webinar series. This is just a standard slide that I put at the beginning of every presentation I do. I'm not going to be talking about any off-label use, and perhaps of interest to this group, I'm not paid to encourage you to follow any particular course of treatment. I don't have any financial interest in any company for any of the products that I'll be talking about tonight. So perhaps we should start by defining what exactly is SCOPE. So in 2014, the American Academy of Optometry held a special interest group on clinicians who were interested in doing research, and they called it Fellows Doing Research. We got together at that point and received some early mentorship from that group, and we decided that what we really wanted to do was to perform translational and clinical research that would inform scleral lens prescription and management practices. At the time, in 2014, scleral lenses were just sort of taking off, and so there was a lot that we needed to know about them. I'm very fortunate to work with 5 wonderful women. Jenny Folk is at the Ohio State University School of Optometry. Dr. Amy Now is at the Korb and Associates Eye Care Practice in Boston. Dr. Jennifer Harthan is at the Illinois Eye Institute. Dr. Ellen Shorter is at the University of Illinois at Chicago Eye Institute, and Dr. Sherry Now works with me at Mayo in Rochester. We have been working together for a number of years, and several years ago, Mary Pruden, who I'm sure you all know, approached us at an ophthalmic research program and said, hey, you should really do a study about keratoconus. She volunteered to help us with that study by distributing any surveys that we may want to use to the membership of the National Keratoconus Foundation. And the result was this study. It's a patient assessment of contact lenses and keratoconus. So we are going to be going over the results of that study tonight, and I will be musing just a bit on how that might be related to your lives as patients with keratoconus or family members of patients with keratoconus. So as you probably know, keratoconus is the most commonly reported indication for scleral lens wear. About 75 to 80% of scleral lenses are fit for patients with corneal irregularity. It just gives them better vision. And a majority, anywhere from 50 to 80% of patients within that category have keratoconus. Now, there are other conditions in that category that can cause some irregularity as well. For instance, if somebody has had a corneal injury or scar, maybe they've had surgery, maybe they had refractive surgery that didn't go as planned, but keratoconus is by far the most common indication for scleral lens wear. The other bit of background information that made us interested in this topic is that patients with keratoconus may be more likely to experience symptoms of dry eyes than individuals without the condition. So patients with keratoconus very frequently also have allergies. That can make their eyes itchy. It can decrease the quality of the tear film. It can just make you uncomfortable and a little bit miserable. The fact that you are more likely to have these dry eye symptoms is another indication for scleral lens wear. Dry eye symptoms overall can be exacerbated by contact lens wear because a normal contact lens is going to sort of split the tear film in half. Some of the tears will go in front of the lens, other tears will go behind the lens. And that lens rests right on the cornea, which is the most sensitive tissue in the eye. A scleral lens, on the other hand, actually rests on the white part of the eye, or on the clear tissue that overlies the white part of the eye, if we're going to be technically correct here, and allows for maintenance of a fluid reservoir behind the lens and in front of the cornea that should make you a little bit more comfortable. So for patients with keratoconus, scleral lenses may treat both the dry eye symptoms and the visual symptoms of this particular condition. So that's why a group of researchers who were interested in studying scleral lenses ended up doing a survey in keratoconus patients. So the survey development was somewhat interesting. We had done a couple of surveys before and basically wanted to get as much information as we possibly could. Like I said, the survey was distributed by the National Keratoconus Foundation. Some of you might have actually participated in the survey. If you did, many thanks. Your pooled responses have given us better insight into a patient's actual experience with this disease. We wanted to directly distribute this survey to patients. When you go into your doctor's office, the doctor may have a limited amount of time with you. You may have a list of things that you want to address with the provider, and to add a survey on top of that may be a little bit difficult. The other thing that we wanted to avoid was any bias in your responses based upon what you thought the doctor wanted to hear. Most people want to please other people. And so if your doctor is asking you questions about how satisfied are you with your vision or the comfort of the lenses, even if things aren't going perfectly well, you may be tempted to say, you know what, it's okay. You worked really hard to get these lenses for me, and I'm grateful. But we really did want to get your unvarnished opinion as to how things were going for you with your lenses. And so we did want to distribute directly to patients, and we're very grateful to the National Keratoconus Foundation for allowing us to do so. We're going to divide today's presentation into two main topics. First of all, we're going to go over the results that addressed kind of a broad range of areas for concern for patients. Of course, we are all concerned about the clarity of your vision, but sometimes doctors can almost become more concerned about that than they are about anything else. And as Dr. Marsack pointed out several years ago in an editorial that he wrote for a contact lens journal, patients aren't always most interested in getting the best possible vision if the comfort or cost or convenience isn't what they are able to tolerate. So clarity is important. That tends to be what we as providers are most interested in providing, but patients are also interested in comfort. And we need to be aware of the cost of various interventions, not only of the initial cost of the lenses, but also ongoing costs for medical care and maintenance of the lenses. And then convenience. How easy is it to wear or to utilize the correction that we prescribe? So that'll be the first section. After we are finished talking about that, we'll pause for some questions, and then we're going to get into some kind of softer topics, kind of assessing the patient experience with various modalities for treatment. So what happened with the survey? Well, 422 people actually responded, and we are grateful for that because this was a long survey. I think there were 30 or 40 items, most of which you should be able to answer off the top of your head, but some of which required some thought. So if you did participate, thank you for hanging in there during the entire thing. We really appreciate it. The mean age was 46.9 years, but we had a pretty wide range from 15 to 87 years of age. The male-female ratio was 160 men and 256 women. The majority of the respondents were from the United States, but about 25% of them were from elsewhere, representing an additional 36 countries. So it was a worldwide survey, although the predominant responses were from the United States. So we asked a little bit about keratoconus history. The mean age at diagnosis was about 25.7 years. The youngest person diagnosed was age 4, and the oldest was diagnosed at the age of 60. Both eyes were affected in 380 patients, and unilateral disease was reported in 42 patients. Now, the mean age of diagnosis seems a little old to me. But when I think about how keratoconus gets diagnosed, perhaps it isn't. Keratoconus can actually start developing in the teen years, but if it's mild in those teen years, patients may be tempted just to think that they can get a new pair of glasses. And maybe the new pair of glasses does work for a while. But with our more advanced imaging technology at this stage in the game, early diagnosis is important. So if you are a patient with keratoconus, or you are the parent or a loved one of a patient with keratoconus, know that there is at least some genetic predisposition here. So if you have a parent with keratoconus, for instance, wouldn't be a bad idea to get you or yourself tested. If you are a person or a parent with keratoconus, it might not hurt to get your kids tested just to make sure that they don't have any early signs of the disease. The reason that that's important now, more than it was even a couple of years ago, is that early treatment may help to slow or even prevent progression of the disease. So hopefully, if we're giving this presentation 5 or 10 years from now, we'll have a very different experience to talk about. Keratoconus is normally a bilateral disease, but certainly can be quite asymmetric. So it's possible that some of those patients who reported unilateral disease actually had subclinical disease in the other eye. But that kind of gives you an idea of who we surveyed. We asked the type of provider that provided the majority of care for patients with keratoconus. Roughly 50% of the respondents stated that they received the majority of their keratoconus-related care from an ophthalmologist. About 40% received the majority of their care from an optometrist, and about 8% received the care from a contact lens technician rather than an MD or an OD. So it's kind of interesting to note this because we actually made patients tell us who they received most of their care from. It's distinctly possible that a patient may receive care from all 3 of these specialists. For instance, an ophthalmologist may perform cross-linking. An optometrist may follow long-term changes in the cornea, and a contact lens technician may initiate and refine contact lens fitting. So although we only allowed participants to give us one answer, it's possible that more than one care provider would be involved with the care of any individual patient. And actually, an integrated care team tends to be pretty effective in management of a lot of these chronic conditions, such as keratoconus, pellucid marginal degeneration, even things that are not corneal in nature, such as glaucoma, macular disease. So if you can find a care team that consists of both surgeons, non-surgeons, contact lens specialists, you might actually be very well served. We also asked them who or what was your first treatment, and the vast majority of the eyes were treated first with corneal rigid gas permeable lenses. Now, this sort of makes sense. Many of these patients have been diagnosed for 10, 15 years, and prior to this survey, scleral lenses really hadn't been around all that long. A few patients actually were treated with glasses first. As keratoconus progresses, that becomes a little bit less of an option. Soft contact lenses were prescribed for a few patients or a few eyes as a first line of treatment. Soft lenses back 10, 15 years ago were of limited value, but now we do have some decent soft lens options that may actually help to reduce some of the distortion that patients with keratoconus experience. Hybrid lenses are in there as well, with about the same number of people who were treated with scleral lenses initially. Piggyback lenses are a possibility, although they do tend to be reserved for people who can't wear other lens modalities, because now you're dealing with 2 contacts for each eye as opposed to just 1. Intacts were prescribed initially for just a couple of eyes. That is a surgical treatment, and so it stands to reason that surgery would be considered after some of the optical corrections that we have available. But corneal cross-linking was the first treatment offered for at least several eyes. And again, I think that if we repeated this survey in 5 years, we would come up with a different set of answers. First of all, one of our other studies has now shown that scleral lenses are considered first-line treatment for corneal irregularity even more frequently than corneal rigid gas permeable lenses. So I think that if we repeated this study 5 to 10 years from now, we'd see a lot more sclerals as first-line treatment. Then we asked, okay, how many different types of optical correction have you tried? And let me tell you, patients with keratoconus are persistent, and you need to develop long-term relationships with your providers because you go through a lot of forms of correction. If you think about it, you may start out with glasses, and that might provide you with decent vision until keratoconus progressed farther. Maybe at that point you move to soft contact lenses or hybrid lenses. When keratoconus became more visually disruptive, you might have had to move to corneal gas permeable lenses or scleral lenses, maybe a piggyback lens. So most of you have actually tried multiple forms of correction, and that's perfectly logical and perfectly reasonable. As the disease progresses, you will need different forms of correction. And as you move through life, you will need different forms of correction. At some point in life, it may be difficult to manage a contact lens, and if visual demand is not acute at that stage, maybe glasses are okay. Now that we've all been staying home for the past year and doing our work via Zoom, glasses might be okay for some of those tasks. If you were out and actually having to drive, maybe you would need corneal gas permeable lenses. So I encourage patients pretty frequently to consider what they need for a particular visual task, and don't feel like you can only have one option. It's possible that corneal gas permeable lenses will work better for some things, while scleral lenses might work better for others. So if you find that multiple forms of correction will work for different tasks that you need to perform or different activities that you wish to engage in throughout the course of your life, you are certainly welcome to utilize as many forms of correction as you want. I'll sometimes tell patients that they have more than one pair of shoes. You might have one pair of shoes that you wear when you're running, maybe a different pair that you wear when you're doing yoga. If you're going to get all dressed up and go out for a fancy meal or a concert, you might wear a different pair of shoes. If you're going to golf, you might wear a different pair of shoes. So just as you wear different pairs of shoes for different activities, you might find it helpful to wear different modes of correction. And your eye care provider can help walk you through what might work best for various options. So current optical correction, this is where we see that scleral lenses are becoming more common. They may not have been the first option tried, but they rival rigid gas permeable lenses in frequency of use. Soft contact lenses, as keratoconus progresses, not surprisingly kind of drop off. I found it interesting that so many patients with keratoconus do consider glasses their primary optical correction. Many of these patients may have undergone keratoplasty, however, and it's possible that glasses prescriptions don't need to be quite so extreme after transplant surgery. So what kind of surgical interventions have people undergone? Well, penetrating keratoplasty is by far the most common, but some of the newer procedures, such as cross-linking and deep anterior lamellar keratoplasty, are gaining ground. My guess is that as we become more familiar with the advantages of cross-linking, we may be seeing a lot of that procedure. It's relatively minimally invasive. It does not require stitches, so to speak. Patients keep their original cornea, so you don't end up with that pulling and tugging and irregularity in the graft just due to sewing someone else's cornea into your eye. So I think that cross-linking holds a lot of promise. Intacts are a relatively small but steady form of surgical intervention. Some patients find them to be helpful. I think that deep anterior lamellar keratoplasty has great promise. And so if you are a patient right now who is kind of thinking, well, it's about time to do a surgical procedure, but I'm doing okay with my contacts, maybe I should go ahead and do one anyway, I would hold off just a little bit. Let us get a little bit more experience with DALK, because if we can leave part of your cornea intact, it may lead to better visual results compared to penetrating keratoplasty, which has been the surgical treatment of choice. So stay tuned on that. I think there's some exciting developments that will be occurring in the coming years. So we wanted to look specifically at those 4 C's we talked about: clarity of vision, comfort, convenience, and cost. And whenever I'm having a discussion with a patient, I've always got these things kind of in the back of my head. So I saw scleral patients today, or I saw initial evaluations, I should say, for scleral lenses today. So I always start with figuring out what a patient can see with their current correction. And then if I can get a big improvement in their vision with a scleral lens, they get some clarity points. Now, if they've been wearing lenses that they've been finding uncomfortable, or if they've got extremely dry eyes, they may get some comfort points as well. I will admit that scleral lenses are not the most convenient things to wear. There are several solutions that need to be used in order to maintain lens clarity as well as lens sterility. So it's not necessarily as easy as putting in a single-use soft lens and then tossing it at the end of the day. And then cost is certainly a consideration as well. Scleral lenses can be more expensive than corneal lenses, and then given the fact that they do require some additional solution, ongoing care might be a little bit more expensive. So we ask overall, how satisfied are you with vision, comfort, and ease of use? And we actually asked these as 3 separate questions, but I think that the patients who answered this tended to be approximately evenly distributed for all 3 of those things. So over half of keratoconus patients are either somewhat satisfied or very satisfied with vision, comfort, and ease of use with their current correction. 12% are neutral, and about 25% are either somewhat dissatisfied or very dissatisfied. So there's 2 ways of looking at this. You can say, well, gosh, we got over 50% that are satisfied, very satisfied, or somewhat satisfied. I tend to look at the 25% who aren't and wonder to myself what we could do to improve the experience for those patients. Then we talked about some very specific comparisons between corneal versus scleral lenses. It turns out that we had 77 patients who wore corneal lenses in both eyes and 76 patients who wore scleral lenses in both eyes, and so we were able to do some nice comparisons there. Vision was assessed roughly the same in both corneal and scleral lenses. So Scleral lens wearers tended to be either very satisfied or somewhat satisfied with their vision, and frankly, corneal lens wearers did as well. So visually, it seems that corneal and scleral lenses are roughly equivalent, although scleral lenses were just slightly more satisfied. Nonetheless, about 71% and 74% reported some difficulty with their vision. So they were satisfied overall, but was it perfect? No. 3/4 of patients still had some visual difficulties despite the fact that they were wearing lenses that were providing the best vision that we can offer at the moment. Halos and starbursts were reported more frequently by scleral lens wearers, and cloudy vision was reported more frequently by corneal lens wearers, which I was kind of interested in because one of the things that happens with scleral lens wearers is a phenomenon called midday fogging. If you wear scleral lenses, you might have heard of this, but sometimes after a lens has been on the eye for anywhere from 4 to 6 hours, you'll notice that your vision starts to become a little hazy or cloudy. We think that that is due to the accumulation of debris in the fluid reservoir that's trapped behind the lens, but we're not really sure of that just yet. So we were kind of surprised to find that cloudy vision was actually more frequently reported in corneal lens wearers. Halos and starbursts are difficult for scleral lens wearers and for corneal lens wearers. Given the fact that a corneal lens actually may compress the central cornea, we may actually see a diminution of some of the aberrations within the internal cornea in a corneal gas perm wearer as opposed to a scleral lens wearer. So overall, vision is similar between the two groups, with scleral lenses maybe being slightly more satisfying than corneal gas perms for in terms of vision. Let me take a look at comfort. Now, we had expected that scleral lenses would be considerably more comfortable than corneal lenses just because of where they sit. And certainly a much higher percentage of scleral lens wearers were very satisfied with their comfort compared to patients who wore corneal lenses in both eyes. But still, over almost 40% of corneal gas perm wearers were either somewhat satisfied or very satisfied with the comfort of their lenses. So that was good news for those of you who still like to wear your corneal lenses. They're just fine. So once again, overall, scleral lens wearers were just a bit more satisfied with comfort than rigid gas permeable lens wearers. Again, however, just as we noticed that 3/4 of patients were having problems with their visions at least some of the time, roughly 3/4 of patients are still having some trouble with discomfort while they're wearing lenses. Corneal lens wearers were more likely to report spontaneous dislocation of lenses. And those of you who wear corneal lenses might have experienced this. If you look one direction or the other quickly, that lens could dislodge it. I've actually had patients where the lens comes off the front surface of the eye rather than just moving to a different part of the eye. So that irregularity on the cornea can certainly cause some dislocation. Corneal lens wearers were also more likely to report excessive contact lens movement, which is also not surprising. Scleral lenses are so huge, they really don't move much once we get them on the eye. And then we talked about convenience and ease of use. So how do people feel about, are they satisfied with how convenient it is to wear their lenses? We had expected that scleral lenses would be much worse than corneal lenses just due to the need to remove the lens midday at times, the fact that you need to fill the lens with saline. Many people use plungers to put the lenses on and take them off. So we thought corneal lenses would beat scleral lenses hands down here. Really not as much of a difference as we had anticipated. There was really no significant difference in patient-assessed ease of use between corneal rigid gas permeable lenses and scleral lenses wearers. So scleral lens wearers reported some difficulties removing lenses more frequently than corneal lens wearers. But other than that, not a huge difference between the two groups, which is encouraging and somewhat surprising. So we did talk about a little bit of an additional convenience assessment in assessing approximately how long a patient spent every day fiddling with their lenses. And again, we expected that corneal lens wearers would spend much less time working with their lenses than scleral lens wearers. And as it turns out, not hugely different there. There was a higher percentage of scleral lens patients who spent 11 to 15 minutes per day taking care of their lenses compared to less than 5 minutes in corneal gas perm wearers. But the majority of, or the most commonly reported amount of time was about 6 to 10 minutes. Now, this sort of goes along with previous studies of scleral lens application and removal facility. The first 5 to 8 weeks can be rough, but beyond that, patients really get pretty good at putting them on and taking them off. Perhaps I shouldn't admit this in this audience, but I am not able to put a scleral lens on my own eyeball. If I was told that I had to do it, it would probably take me about half an hour to do so. I can put them on other people all day long, but I'm not very good at putting them on myself, and I'm always astonished at patients as young as 7 or 8 and as old as 97 or 98 who take this in stride and just learn how to do it and get it done. So perhaps the lack of convenience of scleral lenses is a figment of my imagination as opposed to actual patient experience. And then the fourth C is cost. So we asked this in a couple of ways. We asked what was the overall estimation of annual expenses, and roughly 50% of you said that you spend about $1,000 to $3,000 a year on contact lens care, maintenance, and eye care. That's a budget item. That's not an inconsequential amount of money. About 26% of you reported that you spent under $1,000 a year, and a very small percentage spent more than $10,000 a year. So not an inconsequential cost, but I was glad to see that very few reported annual costs in that $5,000 to $10,000 range. Then we asked, what have you spent on your eye care related to your keratoconus during the course of your life? And here we start creeping up a little bit more. So we've got 15% who reported that they have spent more than $10,000, and this is out-of-pocket expense during the course of their lifetime. Only 30% who had spent $1,000 to $3,000, only 16% who'd spent under $1,000. So this is a disease that has a fair financial burden in addition to the visual burden, comfort burden, and convenience burden. So scleral versus corneal cost assessment, it looks like corneal lenses might be just a little bit cheaper than scleral lenses for a couple of reasons. First of all, the lenses themselves tend to be a little bit less expensive, and then the care products that you need to use in order to care for lenses also tend to be just a little bit less expensive in corneal rather than scleral lenses. So how many of you have heard of the Wii Fit table tilt game? I got really good at this once. I currently have all of the high scores on my family's ancient Wii game. But you're trying to balance and keep these little balls from falling off. And that's kind of what I feel like we're doing when we're trying to fit a patient with keratoconus into contact lenses. We've got to balance those 4 C's in a way that makes sense for the patient. And we can't put all of our eggs into the vision clarity basket if that's not the patient's priority. So we also have to recognize that there are shifting priorities throughout the course of life. For instance, as you move through your life, you're going to have different visual demands. If you are going to law school, you're going to have a fairly robust, detailed visual demand. But if you end up being a motivational speaker after you're done with law school, you might not have that near demand. And so different forms of correction, as I mentioned earlier, may work better for you throughout different parts of your life. You may find that one form of correction works best when you're at work, and a different form of correction works better for you when you are skiing or gardening. And as I mentioned earlier, you don't have to pick one door. You can use as many forms of correction as you want in order to meet the needs that you encounter within your visual world. So what can we conclude from all of this? Well, as we discovered when we looked at the number of different types of correction that patients with keratoconus had tried, managing keratoconus is a marathon. It is not a sprint. So finding a provider that is willing to work with you through that entire marathon is a very good idea. There is not one perfect treatment option for this condition. So if you logged on tonight hoping to find the answer for what would be the best option, there isn't one treatment option that's best. It's somewhat dependent upon patients. It's dependent upon your visual needs, your visual environment, your visual priorities. But just know that there are a lot of treatment options out there, and your provider should be able to work with you to find the ones that work best for you. And although progress has been made, there is still ample room for improvement. I know that Dr. Marsack has been doing a lot of work with correction of higher order aberrations in scleral lens, with scleral lenses, because they are a very stable platform. And it's possible that we'll be able to give patients better vision once we're able to incorporate that into your contact lenses. So I think with that, I am going to take a brief, I'm going the wrong, here we go. Break for questions. Dr. Marsack, are there any questions that have been asked so far?
Yes, actually, we have quite a few. Let me look at a couple of them to start with. So you had talked about intacs as one of the corrections or one of the methods that was reported in the scope study. Do you personally, have you had any experience fitting sclerals over an intac? Is that something that's challenging? Is it commonly done?
It can be done, and with some of the newer scleral designs, it's much easier than it was with the original designs. The problem is that you've got that elevated area over the intact, kind of in the peripheral cornea, and so a lens with a normal shape, which is steeper in the center and then flattens to the edge, can sometimes ride right on top of that. At this stage in the game, we've got lots of options for scleral lenses. So we can fit a lens that's flatter in the center and maybe steeper over that knee, if you will. So it's certainly possible to fit patients with intacs, but it does not make scleral lens fitting easier, I'll tell you that.
Right. Yeah. We have another question. You know, cross-linking is kind of, I don't know if you'd call it like an up and coming or whether it's here. I don't know how you might categorize it. But for individuals that may be older now,
yeah.
You think there's a time when is it maybe still beneficial for individuals that are older? How do clinicians make the call on when it's appropriate to do cross-linking?
That's a very good question. Nature actually does a pretty good job of cross-linking over time anyway. So if I were to, pick a general age, I'd say 35 to 40. I'd certainly want to see documented progression of disease before I would proceed with cross-linking, but I do tend to be a little bit on the conservative side. I know that there are individuals out there who will cross-link no matter what. We do tend to want to document progression in patients in their 30s and beyond before we would cross-link, but certainly up to age 30, and certainly if somebody is in their teens or early 20s, that's the period of prime progression. That's when it's likely to get a whole lot worse. So if I see somebody who could potentially, who's still doing okay with glasses or even a soft contact lens with signs of keratoconus on corneal topography in their teens or 20s certainly would not wait an awful long time to cross-link. I'd be a little bit more aggressive on that. But yeah, you're right. And nature kind of takes care of that over time. And the disease does not continue to progress forever.
Right. And I think you're making a really important point in that am I right that cross-linking is more about slowing or halting or, is not progressing versus correcting?
Oh, absolutely. So if you can catch a patient with, we call it form fruste or early keratoconus, maybe even subclinical, maybe you don't even know you have keratoconus yet, but if you've got topographic indications of disease and other risk factors for that disease, if we can cross-link you and prevent progression early, that's so much better than trying to pick up the pieces later.
Yeah, and is there any are there any long-term studies or data to suggest that cross-linking does or does not make you a good candidate for other procedures you talked about, like transplant types procedures or anything of that nature, DALK, for instance?
That's a really good question. I must say that I'm not personally aware of any literature on that, at least from the U.S. I do know that
it's still early. We're still early. I mean, cross-linking has been around for a while, but it is still. I mean, is that fair to say?
Yeah, I think that's very fair to say. Just like DALK, that's a new procedure. And maybe this is just me being old, thinking that anything under 15 years old is pretty new. But, we've had Intacts for a while. We've had corneal rigid gas permeable lenses forever. Hybrid lenses have been around for a while. So in terms of treatment options, cross-linking is new. DALK is new. I think that if you think about the physiology of what happens when you cross-link, you're just basically stabilizing the anterior portion of the corneal stroma. So I don't think it would have any negative implications for surgery later on if you needed it, but hopefully with cross-linking and better options for contact lenses, we could reduce the need for some of those more aggressive surgical procedures.
Sure, right. Actually, we had an individual on the webinar, I think it was 2 webinars ago now, a corneal surgeon who said he had seen a big shift in the number of corneal, like penetrating keratoplasties that he was performing, and he attributed at least some of that reduction to the increase in popularity of cross-linking.
Oh, I'm sure. I think between better contact lens correction and cross-linking, which is a less invasive procedure than penetrating keratoplasty, we're going to really be able to reduce the amount of trouble that keratoconus causes within the next couple of decades.
Right. So we have another question kind of on the topic of progression. When you think about correcting someone with a contact lens, are you thinking also about slowing down their progression with a contact lens fit?
I wish I could say yes.
I'm sorry, go ahead.
But I wish I could say yes to that, but I don't think there's any strong evidence that any particular type of contact lens can actually slow the progression. This is a disease process that's happening in the cornea. Stromal fibers are abnormal, and so putting a contact lens on gives you better vision. It kind of smooths out the hills and valleys, but I don't think it slows the disease process. I wish it did.
Yeah. So in that sense, it's maybe more shaping the first surface, which helps light refract.
Right.
Yeah.
Yeah, getting rid of some of that irregularity.
Sure. We have a couple of questions on complications, but I think I'll wait until the next section. I think it might fit better there, but I do have just one, maybe 2 more that we've got here. This is a bunch of really nice questions this evening. So in your study, did you find a big differences in terms of, did they talk at all about where they were getting their scleral lenses? I mean, did they tend to be a certain type of lens, or was that not something you asked?
That wasn't something that we asked for this particular study, but we have done other studies where we've looked at prescribing patterns. And I can tell you that the average lens diameter is about 16 millimeters, between 15 and 17 millimeters. And most of the lenses that were prescribed, even as late as 2016, 2017, had spherical or toric haptics, which meant that, you know, they didn't necessarily shape exactly to the patient's eye, but really within the last couple of years, we've had such great advances in scleral lens technology. We're now doing image-based lenses, we're doing impression-based lenses. So I think if somebody has tried a scleral lens, you know, back in 2015, 2016, wouldn't necessarily discourage them from trying it again now, because we've got some better options out there.
Right. Yeah, the advancements kind of keep on coming in that way.
They sure do.
Last one for now. So I believe this question is originating from an individual that does themselves have keratoconus, and they're thinking about, you had mentioned about their children getting screened. Do you have a recommendation on how often you would recommend, like, children of someone with keratoconus maybe visit their eye care professional?
If a child is nearsighted at all, whether or not they're at risk for keratoconus, I really do recommend annual examinations. If a patient, or if a child is a parent or has a parent with keratoconus, I would actually recommend just getting a pentacam, which is a pretty simple means. It's non-invasive. The kid would just have to look at a spinning blue light for about 30 seconds. And it would really give us a lot of information on that cornea. So if the cornea looks completely normal, then I'd say probably screen with a pentacam every 2 or 3 years until the child hits early to mid-20s. That's what I would do. Again, I can't say that there's a lot of strong evidence for this, but to be on the safe side of things, if there's any sign of abnormality, I would follow that child even more carefully.
Yeah, and I appreciate your the idea of the pentacam, because that does give you, additional information on both the anterior, front and back surface of the cornea, as well as its thickness, and it's kind of designed for this kind of thing. So that's really a great recommendation.
Right.
Yeah. So we have a couple others on some complications, but looking ahead at the slides, I think they might fit there better. So why don't we come back to these last two towards the end?
Sounds good. All right. So let's move on to just kind of assessment of a general experience. And we're going to talk about 3 main areas here. We're going to talk about patient relationship with the eye care provider, impact of keratoconus on activities of daily living, and eye discomfort or dry eye symptoms with keratoconus. So with regards to finding a provider, 123 individuals said that it was easy to find a provider who had expertise in keratoconus, but 296 found it difficult to find someone with that sort of expertise. This is very unfortunate, in my opinion. I would very much like for all patients with keratoconus to find someone who understands this condition and can walk you through those treatment options. So certainly leverage your assets here. You've got the National Keratoconus Foundation. If you are going to a provider for general eye care who doesn't do fitting or contact lens fitting, or doesn't seem to be well versed in the most recent and exciting developments in the management of keratoconus, ask for a referral. None of us is an expert in everything. That's one of the things that I've learned at Mayo. If somebody walks in with glaucoma, I am not their gal. But if somebody walks in with keratoconus, or someone needs a specialty contact lens fit, that's what I do. So I will happily send patients with retina issues or optic nerve issues to some of my colleagues who specialize in that. And they will happily send their patients with corneal issues to me. So if you are having difficulty finding a provider, ask your current provider to give you a referral to a specialist in that area. Once you find a provider, you tend to be pretty happy with them. About 3/4 of you believe that your provider has the most up-to-date information on keratoconus. Only about 1/4 of you had some reservations about your provider's knowledge. So with regards to complications, 36%, so well over 1/3 of patients with keratoconus who replied to this survey reported an issue that required an unscheduled visit to the doctor during the past 2 years. Now, this could be potential loss of lens, it could be eye drops, it could be graft rejection if a patient has undergone penetrating keratoplasty. We didn't specify exactly what those complications might be, but 30% is a high number when you consider that the average rate of complications of the most serious complication of soft contact lens wear, which is microbial keratitis, is about 4 per 10,000 per year. Now, I'm not implying that only 4 patients who wear soft contact lenses out of 10,000 per year have a complication, but the rate of complications with keratoconus patients seems to be higher. 34% of you reported an issue that required temporary discontinuation of contact lens wear during the past 2 years. And that is a particularly important issue for you because when you cannot wear your contact lenses, you really can't function fully visually. So this is one of those areas where I think we need further study. What are some of the causes of complications? What are the risk factors? And then we need good ways to mitigate those risk factors in order to keep you in your lenses because you really do need them in order to get through your days. We then talked a little bit about the impact of keratoconus on activities of daily living. And this was not in any form of a validated survey, but we just said, okay, during the last year, how often have you had trouble driving because of keratoconus? How often have you had trouble doing your job or your schoolwork or engaging in your hobbies or even enjoying social activities? And a majority of patients reported that they had trouble with all of these things, at least some of the time. So keratoconus is a condition that can have an impact on the rest of your life. So that just speaks to the importance of finding a provider who can help you maximally enjoy and participate in all of these activities. Then we took a look specifically at dry eye issues and keratoconus patients. There is a validated survey called the Ocular Surface Disease Index, or the OSDI. It's divided into 3 main parts, and it asks patients if they have, during the course of the past week, experienced any of the following symptoms. So eyes that are sensitive to light, eyes that feel gritty, painful or sore eyes, and then asks patients to quantify the number of times that they experienced all of these things. And again, some, half the time or most of the time, does make up a fair percentage of the patients that we surveyed here. So sensitivity to light, grittiness, painful or dry eyes are pretty common in patients with keratoconus. The next section of the Ocular Surface Disease Index has symptoms that could be associated with dry eyes, but could also be associated with just the visual distortion you get with keratoconus. So again, we asked how often during the course of the past week have you experienced blurred vision, poor vision, difficulty reading, difficulty driving at night, difficulty working on the computer, and the survey actually says, or operating an ATM. How many of us even use ATMs anymore? I think maybe they need to update that a little bit. And how many of you have difficulty watching television? And again, a fairly robust percentage have trouble some, most, or all of the time. Moving on to the next section of the Ocular Surface Disease Index. How many of you have experienced symptoms in windy conditions, places with low humidity or areas that are air conditioned? And again, you'll see the percentage or the number of patients who experience these things. Some, most, or all of the time. It's pretty high. So when we put all of these things together and assessed dry eye disease in patients with keratoconus who responded to this survey, the majority of patients would be classified as having severe dry eye syndrome or symptoms. Now, again, it gets a little bit messy because some of these symptoms could be caused by corneal irregularity or dryness, but nonetheless, it shows that symptoms are pretty common. The other thing that we wanted to take a look at was some of the things that can kind of go along with keratoconus. For instance, sleep apnea or floppy eyelid syndrome may be associated with keratoconus, asthma or difficulties breathing, allergies. A lot of folks with keratoconus have allergies. The one that we were particularly interested in was depression or just having some difficulty dealing with a chronic disease that manifests in your teens and 20s and just doesn't let up. And about 19% of respondents reported that they have suffered from depression. So that is a real issue with keratoconus patients. This suggests that perhaps we should not be concentrating exclusively on the eye symptoms that go along with keratoconus, but we should make sure that patients with keratoconus are also plugged into the rest of the healthcare system to make sure that we're dealing with other issues that may be arising. So what can we conclude from this section? Well, first of all, finding a qualified provider isn't always the easiest thing. In addition to causing problems with vision, keratoconus can cause some ocular discomfort issues as well. And then it's really important to plug patients with keratoconus into the overall healthcare environment. So what can you do? Like I said before, advocate for the care that you need. You've got available resources through the National Keratoconus Foundation. If you have an academic medical center in your area, that's usually a good place to find a cornea specialist or a contact lens specialist. Specialty contact lens practice may actually be helpful. You can certainly get contact lenses from an eye care provider who doesn't specialize in that, but if you are having some trouble with your current lenses, and according to this study, up to 3/4 of you are having either some vision or comfort issues with your current lenses, although you're overall pretty satisfied with them. It wouldn't hurt to make sure that you're seeing somebody who really does specialize in this and who can help walk you through your options and show you what's available. All right, so the second portion was much quicker than the first portion here. You'd asked about complications with regards to keratoconus, and I'm more than happy to elaborate on that if you'd like to explain the questions a little more thoroughly.
Yeah, sure. We have a couple related. So, you know, I think a lot of the questions can be very specific to an individual, but if I could maybe broaden it out a little, have you had anyone who simply was not able to wear a scleral lens, who even with your best effort and theirs, it just didn't work? And perhaps have you ever had anyone who's maybe suffered an injury from wearing the scleral lens? Anything in those two?
So have I ever had a scleral lens failure? Oh yeah. I certainly have. In both of the other scope studies, we did ask about reasons for discontinuation. And one of the main reasons for discontinuation in scleral lenses is just handling difficulties. As I mentioned earlier, that first 5 to 8 weeks is rough because you got to get your lids out of the way, your hands feel huge, your eyes feel tiny, you're putting this lens on a plunger. It's somewhat like learning how to drive a stick shift car after you've been driving an automatic all your life. Or maybe it's like learning how to write with your non-dominant hand. It's not simple. If patients are able to get through that initial period, they tend to be pretty successful. with scleral lens wear. With regards to injury to the eye with scleral lenses, well, I worry about this frequently because basically we're giving you a sharp object and we're telling you to poke your eye with it. I've had a couple of instances during the last 15 years where a patient has actually jabbed the side of the lens, the edge of the lens into the cornea. That can cause a corneal abrasion, which is not permanent damage, but is certainly uncomfortable. So that's happened once or twice in the last 15 years. It's not all that common. And with regards to other more serious long-term complications, I'm not seeing a lot of them in patients with keratoconus. You tend to have pretty intact epithelium or outer protective layer cells. I tend to see a few more complications in patients with ocular surface disease or patients who've had transplants. Sometimes those transplants will be challenged with a scleral lens. But in general, if you can get through that first 5 to 8 weeks where you're learning how to put the lens on, I frequently give patients permission to swear at me as much as they want during that process because it can be not very much fun.
Yeah, I certainly remember the first time I attempted to put a scleral lens on, and I my heart rate went up.
Yeah.
It was a nerve. I was a little bit nervous because it is a bigger lens.
Yeah, absolutely. Well, my staff always used to be able to tell when I was practicing putting scleral lenses on my own eyes because I'd come out of the room with a bunch of subconjunctival hemorrhages. I'd have poked myself in the conj too many times.
Yeah. You had mentioned midday fogging. Is there anything on the horizon to maybe help mitigate or reduce the occurrence of midday fogging?
Yeah, so that is a really good question that as of yet does not have an excellent answer. So there have been a couple of theories on midday fogging. One was that material from outside of the lens was getting pulled under the lens and trapped there. If that's the case, then if we could slow tear exchange, we should be able to mitigate those effects. And so there's a couple of ways to slow tear exchange. First of all, you could fill the bowl of the lens with a more viscous solution as you apply it, and that should slow down tear exchange. The other thing that has been widely recommended is that you try to more closely match the shape of the landing zone of the lens with the shape of the front surface of the eye to close out any gaps, if you will. So the scope group did a study in 2017, and we actually had providers describe a single patient to us. We asked those providers to tell us if that patient reported self-reported symptoms of midday fogging. And then we took a look at everything. We took a look at lens diameter, we took a look at lens haptic design, we took a look at lens optical design, we took a look at condition for which the lens was prescribed, we took a look at care products. None of that was associated with an increased risk of midday fogging. So it sort of put us back, maybe not at square one, but certainly no farther ahead than square two. The one thing that did pop up as being associated with midday fogging, patients who reported midday fogging were also more likely to report redness or irritation with scleral lens wear. So it's possible that if you've got some underlying inflammation, and a lot of patients with keratoconus do, a lot of patients have allergies, which is by definition an inflammatory condition. That could be associated with an increased risk of midday fogging. And I've had some success just really aggressively treating allergies with both systemic antihistamines as well as something like a Patanol or a Pataday. Lubricant drops over top of the lenses and just trying to get everything calmed down as best I can. Sometimes that can help to mitigate those symptoms. But as of yet, I don't have a surefire way to say, if you take this one simple step, you're not going to have this problem anymore. Wish I did.
Yeah.
It's irksome. 30 to 50% of patients experience it, according to studies that have been published so far.
Yeah, some of the work I've been involved in, we try and really take a hard look at the optics. But a lot of times we find the most challenging aspects of even those studies are the fit and the comfort and the other aspects you talked about.
Yep.
So yeah, and certainly fogging was a big challenge for us even in those studies. So yeah, I would agree.
Yeah. So there's some new filling solutions out there too that might be a little bit more supportive of the cornea. So I talked a little bit about that exogenous material being pulled under the lens. The other potential source of that debris that we see entrapped under the lens is just from the cornea itself. So if the cornea is shedding a lot of cells into that reservoir, then those cells may get trapped there as well. So to the extent that you can manage or keep the front surface of the cornea happy, you may be able to mitigate the problems associated with midday fogging as well. So more to come.
Right. Yes. So we have a couple questions that are, very much related to like a specific maybe difficulty or challenge for an individual. Something like, is this lens worth the increased cost? I'm having some difficulty using a plunger. The sclerals don't work. What would be a good alternative? And I think, these type of challenges, I think one thing it reminds me of is kind of like you talked about, the importance of the relationship between the care provider and the patient, and trying to really whatever these challenges are for individuals, and we everybody has some of these. It's about that relationship and really trying to get the best for the individual and out of the relationship. Is that a reasonable assessment?
Oh, absolutely. As we talked about before, managing keratoconus is a lifelong relationship. So you've got to feel free to let your provider know when you're having trouble, and let your provider know what kind of trouble you're having. And unfortunately, sometimes the answer is, oh gosh, I can't really do anything about that. But sometimes the answer is, okay, well, let's try this. Some providers are, I've on occasion gotten creative with a patient who is struggling with the scleral lens. If they're worried about putting it on and taking it off, yeah, that's a big pain. There's no question about it. So to give them a little bit more confidence, sometimes I'll let them wear a bandage lens while they're learning how to put it on and take it off. Sometimes we'll use Celluvisc in the bowl of the lens, kind of as training wheels. There are a couple of devices that can help you get the lens on and take it off, for instance, if that's the issue. So really be honest with your provider and say, look, I'm having trouble with A, B, and C. And hopefully you've got a relationship with that provider where he or she will be able to walk you through some possible solutions for that. And keep in mind too, that it doesn't have to be an all or nothing thing. You might find that you really appreciate scleral lens wear when you are going to your son's soccer game. But you might find that glasses give you perfectly functional vision if you're bopping around the house cleaning on a Saturday. So that's just fine. Use both forms of correction. You might find that a piggyback system works well sometimes, but is too much of a pain for other times. So there is no rule that says that one solution has to do everything. If scleral lenses won't work for everything for you, that's okay. They might work for some things.
Yeah. No, I would definitely agree with that. If you don't mind, two quick ones, and then we can close out. One, for those of us who are approaching a certain age, certainly I'm getting to this level where I'm having to hold things further and further away to actually see them clearly. Are you aware of bifocal, if there's a bifocal scleral lens option out there? And if so, have people had success with that?
There are multifocal scleral lenses available. They are not translating lenses. So the best vision that you're going to get is when you are looking through pure optics that give you distance correction when you're looking through one part of the lens, and pure optics for near correction through a different part of the lens. And given the fact that scleral lenses don't move, you can't look through different parts of the lenses for different tasks, different visual tasks, or tasks at different distances. But there are some, they call them simultaneous vision lenses, that have correction for near tasks kind of in the center of the lens, and then as you move towards the periphery of the lens, you get more correction for distance. I personally haven't had a great deal of success with these with patients with keratoconus because you're so aberrated, or some of my patients are so aberrated already that the extra aberration that you get when you try to break the laws of physics just tends to be a little challenging and pushes you over the top. But yes, if I had a wish for patients with keratoconus, I would wish that since you already have this eye disease, you should be exempt from having to become presbyopic. Unfortunately, I'm not in charge of the rules.
Yeah, no, I appreciate that. Yes. Last one here. And I really appreciate the fact you kind of speaking to the point. I think you mentioned that you noted in the scope study that 19% of individuals diagnosed, or at least responding to your survey, noted some level of depression. And
Yes,
I think that's
huge.
It's really, I think it's a really important thing to recognize. And I do think there is some scientific literature out there that kind of, I think, tries to speak to this a little bit. And my read of it is it makes sense in a way because of the time in life that the disease tends to present, and the fact that it is progressive in nature. I mean, these are challenging things for an individual to hear.
Yes.
So yeah, so I appreciate you mentioning that. And do you find that in your practice, that do you think about this, like if someone is feeling depressed about this, is it different than someone who might have a different eye disease, or do you find commonality between, say, the way someone may think about keratoconus and a different eye disease?
So I think there are commonalities and there are differences. I think whenever we're dealing with a chronic eye disease that results in difficulties in fully engaging with the world visually, it's just tough because so much of what we do is visual. Think of all the time that folks are spending on their phones and sharing information on social media and going to plays and that sort of thing, and sports events and participating in sports. It's just, it's hard when you cannot fully visually participate. A lot of other eye conditions don't show up until a lot later. So there are some nasty conditions out there. For instance, retinitis pigmentosa can kind of blind a person, but they tend to have had the opportunity to live a visually normal life first. So we're dealing with patients with keratoconus who aren't in their 80s or 90s like patients with macular degeneration or glaucoma. They're in their teens, and boy, that's a tough time of life anyway. So anything that sets you apart in your teens is just really hard to deal with. So they're dealing with a chronic progressive condition that is making it impossible for them to fully engage with their peers when it comes to visual activities. The other thing that we kind of pointed out, how often are you having trouble engaging in hobbies? How often are you having trouble engaging in social activities? And there may be some isolation that comes along with this in a younger individual. So yeah, I think there's commonalities because vision loss is horrible at any age, but I think that there are also some unique features in that a lot of the other conditions that result in permanent loss of vision happen after a person has already been able to fully appreciate normal vision throughout most of their lives. So it's a different ball game with patients with keratoconus. I'm not aware of an awful lot of other conditions that are this common that cause that sort of vision loss at a young age. certainly there are other conditions, but keratoconus is it's not uncommon. I mean, original estimates were 55 per 100,000 patients per year, but that was back before we did topography. The true incidence is likely much higher than that.
Yeah, I would agree. I think that's accurate. It seems like, you know, there's other studies in the Netherlands certainly saying it's much more common across an entire population than some of the earlier estimates. I do think, you know, maybe talking about like this, the impact it can have on an individual, you know, I do think, again, maybe that harkens back to the importance of building an excellent relationship with your eye care provider and really finding someone you're comfortable with and really someone who can really, to the best of address the challenges that, you know, you face as a team really in the clinic.
Yep, absolutely. And, you know, who you are comfortable with might not be the same person that someone else is comfortable with. Maybe what you really need is just the facts. I want to get right down to business and I want this to get fixed. Maybe someone else needs a little bit more opportunity to discuss some of the softer issues that surround keratoconus. So finding that provider that you are comfortable with, and then being willing to open up and share the concerns that you're having with that individual. If I don't know a patient is having a problem, I can't help them fix it. So to the extent that you can be honest and open with your provider, I think that's critically important.
Yeah. Well, this has been very wonderful. I really appreciate this. Thank you so much for your time tonight. We're kind of out of questions. So with that, we would like to sincerely thank Dr. Schornack for describing the results of the SCOPE study, having these question and answer, discussing these things with us. And we would like to thank all of you for joining us this evening. Please join us for our next webinar on March 16th, which will be given by Dr. Sumitra Khandawal, who will be discussing cataract surgery and keratoconus. For more information on that, you can visit the National Keratoconus Foundation website at nkcf.org. Until then, we hope you remain safe and healthy, and for now, goodbye.